You implemented a punishment procedure, and the target behavior dropped to 0.
Yeah.
Success, right? But now your client is crying in the corner, they're avoiding you and showing signs of severe anxiety. So did you actually succeed, or did you just create a much worse problem?
Well, it is the ultimate clinical paradox, right?
Yeah.
You won the battle on your data sheet, but you are actively losing the war for your learner's well-being.
Yeah, exactly.
And frankly, this is where we separate the data technicians from the master clinicians.
Welcome to a special deep dive for behavioral intelligence. Today, our mission is laser focused on BACB 6th edition task list item G.18. Evaluate emotional and elicited effects of behavior change procedures.
Such a critical one.
It really is. We are taking the source material, the mock exams, the ethical guidelines, and breaking down exactly what happens when our interventions create, well, unintended collateral damage.
Because we have to look at those blind spots.
Right. So let's start by defining exactly what G.18 demands of us based on the sources. I mean, when we talk about evaluating emotional and elicited effects, what are we actually looking at in the clinic or the classroom?
We are looking at the dual nature of behavior. Like when we implement behavior change interventions, it is honestly clinical malpractice to only measure the target behavior.
Wow, malpractice, that's a strong word.
But it's true. We must evaluate emotional reactions, things like frustration, anxiety, anger. And we also have to evaluate elicited behaviors, which are reflexive behaviors or conditioned emotional responses.
Okay.
The fundamental concept here is the operant versus respondent divide. We get so busy manipulating operant
The
behavior.
consequences, right.
Exactly. We're busy manipulating consequences, and we accidentally trigger respondent behaviors.
Okay, let's unpack this for a second because I want to play devil's advocate here.
Oh, for it.
If we are hired to reduce a severe, dangerous behavior like property destruction or self-injury, shouldn't the target behaviors reduction be our only metric of success?
You would think so, right?
Yeah, I mean, if a child is putting their head through a drywall, the parents just want that to stop. Why do we care if the learner gets a little frustrated or anxious along the way? Isn't that just the cost of doing business?
Well, if we connect this to the bigger picture, let's test that logic against the long-term reality of behavior analysis.
Okay.
Ignoring those emotional effects isn't just unsustainable. It is a direct violation of our ethical obligations.
Because of the ethics code.
Yes, specifically Ethics Code 2.15, which mandates minimizing risk of behavior change interventions. The sources are incredibly clear on this. You cannot claim an intervention is effective if it is creating psychological harm.
So the ends don't justify the means.
Yeah, not at all. Code 2.15 dictates that we must continually evaluate the effectiveness of restrictive or punishment-based procedures, and we have to modify or discontinue them if they're ineffective or causing harm. An intervention is only truly effective if it is conducive to the overall emotional and, psychological well-being of the individual.
So we can't just throw our hands up and say, well, the property destruction stopped, so my job is done.
Not if you want your intervention to last. Think about the basic science of respondent conditioning just running in the background. As behavior analysts, our bread and butter is operant conditioning.
Right. We manipulate consequences to change emitted behavior.
Exactly. But while you are doing that, the environment is simultaneously acting on the learner through respondent conditioning. You have an unconditioned stimulus that elicits an unconditioned response.
Okay, I'm following.
Over time, neutral stimuli in the environment, like the classroom, the teaching materials, or even you, the therapist, are paired with that aversive situation.
Wait, so while I'm entirely focused on the consequence, delivering a token or implementing the timeout, the learner's nervous system is just associating things. It's classical conditioning happening invisibly.
Inevitably. And suddenly, you become a conditioned aversive stimulus. The client sees you pull into the driveway and instantly feels anxiety or fear. That is an elicited emotional effect. If the client is terrified of you, your intervention lacks social validity, regardless of what the frequency data on property destruction says. They will eventually learn to escape you, avoid the therapy room entirely, or engage in counter control.
Let's ground this in the source data because there is a perfect real-world clinic scenario provided that illustrates this exact trap.
Let's hear it.
So a therapist is working with a child who engages in severe screaming behavior. The therapist implements a timeout procedure which functions as negative punishment.
Right. You remove the child from the reinforcing environment contingent on the screaming.
Exactly. According to the data in the scenario, the intervention, quote-unquote, works. The screaming decreases significantly.
Yeah.
But here's where it gets really interesting. The complication is that the child is now displaying extreme emotional distress, crying continuously, showing signs of anxiety, and demonstrating a severe reluctance to even participate in therapy sessions.
Yeah, let's analyze the biological and behavioral mechanics of what just happened there. This is a classic unwanted effect of punishment.
Okay, break that down for me.
The timeout successfully suppressed the operant behavior. The screaming stopped because the consequence of isolation was effective. But the procedure itself, the abrupt removal of positive reinforcement and the isolation, acted as an aversive stimulus.
It elicited a conditioned emotional response.
Spot on. The anxiety and the avoidance are the elicited effects of the behavior change procedure. The therapist was so focused on the operant that they completely ignored the respondent fallout.
Map that out for me just so it's super clear. If I'm looking at this from a classical conditioning standpoint, what exactly is the neutral stimulus turning into the conditioned stimulus?
Initially, the therapy room and the therapist are neutral stimuli, but when the therapist implements the timeout, they are introducing an aversive condition, the sudden loss of access to reinforcement, which, can function as an unconditioned aversive for many learners.
So the unconditioned response is distress or fear.
Right. And because the therapist and the therapy room are repeatedly paired with this highly aversive timeout procedure, they acquire those aversive properties. The room and the therapist become conditioned stimuli that elicits a conditioned response anxiety and avoidance.
The therapist cured the screaming, but gave the child clinical anxiety regarding therapy.
Exactly. And we see this contrasted heavily in the literature with extinction procedures. The emotional side effects of punishment look very different from the emotional side effects of extinction.
Oh, really? How so?
Well, let's say instead of punishment, the therapist used extinction. They identified that the screaming was maintained by attention, so they planned to withhold attention when the screaming occurred. What do the sources tell us to expect there?
Emotional outbursts and punishment-induced aggression. But I'm actually struggling to see why withholding something causes aggression. What is the mechanism there? If you are just ignoring a behavior, you aren't actively doing anything to the learner. Why would they get aggressive?
It comes down to predictability and the history of reinforcement. When an organism has a long history of a specific behavior reliably producing a specific consequence, their environment is predictable.
Makes sense.
When you suddenly implement extinction, you fracture that predictability. You withhold reinforcement that has historically been provided. The organism doesn't just calmly register the change and stop the behavior.
Right. They don't just say, oh, I guess this doesn't work anymore.
Exactly. The sudden absence of an expected reinforcer is functionally aversive. It elicits frustration, crying, and often highly aggressive behaviors. These are elicited emotional effects of extinction. You didn't target aggression, but your procedure created the environmental conditions that elicited it.
Reviewing these case studies and the ethical scenarios in our stack of sources, a phrase popped into my head to describe what clinicians are doing wrong here.
What's that?
It's emotional bycatch. Like, think of a massive commercial fishing net that's meant to catch tuna, but it's pulling up all sorts of other unintended things. Dolphins, sea turtles. The clinicians are staring at the net, thrilled they caught the tuna, and completely ignoring the collateral damage.
That is a highly accurate assessment of the problem. We can call that clinical tunnel vision. It's the first major trap.
Trap number one. Okay.
It happens when a clinician creates a perfectly formatted graph for the target behavior, and they stare at that one data path trending downward, completely ignoring the emotional bycatch happening right in front of them. Our field trains clinicians to be obsessed with data.
Right.
But we rarely train them to graph flinching. We rarely train them to take frequency data on looking for the exit.
Because it's harder to operationalize.
It is harder, but it is no less critical. If you are only tracking the rate of the operant behavior and you aren't monitoring the client's psychological well-being, you are missing half the data.
You have to look at the whole learner.
Yes. Are they smiling? Are they engaging naturally? Or are their shoulders tense? Are they retreating to the corner of the room the moment you stand up? That avoidance behavior is data indicating your procedure is eliciting unwanted effects.
But recognizing that emotional bycatch is only half the battle, right? What happens when clinicians misinterpret why the behavior is happening in the first place? Because this seems to be a huge trap in the mock exams.
Track number 2, mislabeling extinction effects.
Right. Clinicians see a reaction and completely mislabel what they're looking at, particularly with extinction.
The mislabeling of extinction effects is just rampant. The source material explicitly highlights this massive misconception. Practitioners frequently observe the elicited emotional effects of extinction, the crying, the novel aggression, and they incorrectly label it an extinction burst.
Okay, let me try to break this down because I think a lot of people blur those two concepts together.
Let's do it.
If I put $1 in a vending machine and my bag of chips gets stuck, my immediate reaction is to hit the button faster and harder. Maybe I shake the machine. That escalation, the hitting of the button, is the operant behavior increasing because it has a history of reinforcement. That is the extinction burst.
That is the burst. It is an immediate temporary increase in the rate, frequency, or magnitude of the targeted behavior. It is the old behavior getting worse in a desperate attempt to contact the withheld reinforcement.
But the emotional side effect is when I get so incredibly frustrated that the chips didn't fall, that I kick the glass and start yelling. I don't have a history of kicking vending machines to get food. I'm kicking it because the sudden removal of predictability elicited pure anger.
Precisely. One is an escalation of the operant behavior to get the chips. The other is elicited respondent anger. The distinction is vital. Emotional outbursts, crying, or novel aggressive behaviors are unwanted side effects of extinction. They're a distinct phenomena from the burst.
Because the burst is driven by operant mechanics.
Yes. The aggression or emotional distress is a newly elicited effect caused by the frustration of the extinction procedure. Knowing the difference is critical not just for passing an exam, but for how you adjust your clinical intervention.
Okay, so the glass is kicked, the child is crying or hitting during the extinction procedure. Do we stop? Because, the traditional advice passed down in a lot of clinics is push through it. It's just an extinction burst. If you stop now, you'll reinforce the hitting.
And that leads to trap number 3, ignoring the warning signs.
That momentum of the clinical plan makes it very hard for a practitioner to pivot.
It does, but pushing through without evaluating is a direct violation of the ethics code. Section 2.18 requires continual evaluation of the behavior change intervention. If the data indicate desired outcomes aren't being realized, or if harmful side effects are emerging, you must actively assess the situation and take corrective action.
So you can't just blindly stick to the script.
No. Continuing a procedure that causes severe emotional harm under the guise of following the plan is unethical. We are obligated to prioritize positive reinforcement and minimize risk. If your extinction procedure is eliciting severe aggression, you haven't prepared the environment properly, you haven't enriched the environment sufficiently, and you need to step back and reevaluate.
Let's pivot to the exam strategy. Because our listeners are out there studying, they're preparing to sit for the BCBA or BCBA exam. Let's look at the Pearson VUE logic. How do these concepts actually show up on the test?
It's all about the architecture of the questions. The exam writers design these questions specifically to test your ability to separate operant mechanics from respondent side effects. They want to know if you can spot the collateral damage when it's hidden behind a seemingly successful intervention.
Give me an example. How do they test punishment and anxiety?
They will present a scenario where a target behavior successfully decreases. The graph looks great, but the prompt will specifically mention that the client starts crying, attempting to escape the environment, or showing signs of generalized anxiety.
I bet the trap is always going to be a distractor answer that says something like, continue the intervention because the data shows it is effective at reducing the target behavior.
Every single time.
The test writers know that we are conditioned to look for the behavior decreasing.
Exactly. Do not choose that distractor. It is testing your clinical tunnel vision.
So what's the strategy? If this, choose this.
If you see that scenario, choose the answer that addresses evaluating emotional and elicited effects, or choose the answer that identifies these new avoidance behaviors as unwanted side effects of punishment. The exam is testing your awareness of G.18. They want to see that you recognize the respondent behaviors being accidentally elicited by the punishment contingency.
What about extinction? How do they use that vending machine logic to trick you on a multiple choice question?
Well, this raises an important question about how the exam tricks you. They will give you a scenario where an extinction procedure is implemented, and the client starts engaging in a completely novel behavior. For example, the client starts hitting the therapist, and hitting was never the target behavior.
Okay.
The prompt will ask you to identify what is happening. The options will likely include both extinction burst and extinction-induced aggression, or emotional side effect.
Wait, why do they put both? Are they just trying to be cruel?
They put both to test your precision with terminology. If a question asks about the unwanted effects of extinction and gives you options of rate increase versus aggression, remember the exact definitions. If the prompt asks for the unwanted emotional effect or describes a novel topography of behavior driven by frustration, you must choose aggression or emotional side effect.
But if they ask about the old behavior,
Right. If the prompt explicitly asks about an immediate increase in the rate or magnitude of the previously reinforced behavior, you choose burst. Accuracy with terminology is how you logically eliminate the distractors and beat the Pearson VUE logic.
so what does this all mean for the practitioner going into work tomorrow? We've talked about the definitions, the ethics, the exam traps, but let's elevate this. Bring us the advanced application. Give the listener that clinical power insight that separates a test passer from a master clinician.
The insight comes down to the concept of social validity and compassionate care. True behavioral intelligence isn't just about changing behavior. It's about protecting the learner.
That's powerful.
We possess an incredibly powerful science. We can manipulate environments to change what people do. But if an intervention causes emotional harm, it lacks social validity.
Period.
It does not matter how flawless your data collection is. It does not matter if the data path drops perfectly to 0 within 3 sessions. If the client is terrified of you, if they are anxious in your presence, if they are crying in the corner, your intervention is a failure.
But isn't empathy subjective? Like, how do we measure that in a science based entirely on observable behavior?
By evaluating these exact elicited effects. Empathy in behavior analysis isn't just a feeling, it is an active observational skill.
Wait, really? Empathy is observational data.
Yes. Avoidance is observable data. Flinching is observable data. Master clinicians don't just engineer behavior reduction. They build procedures that maintain the learner's dignity and emotional well-being.
They look at the whole picture.
They utilize pairing, they prioritize positive reinforcement, and they are acutely sensitive to the emotional temperature of the room. When you evaluate the elicited effects of your procedures, you aren't just taking data. You're practicing empathy. You are ensuring that the science of behavior analysis is used to uplift, not to traumatize.
That brings us perfectly to our final thought for this deep dive. I want you to look at your own caseload tomorrow. Look at the learners you serve. What if the non-compliance or avoidance you are constantly fighting isn't a skill deficit or a stubborn behavioral trait at all? What if it is an elicited emotional effect of your own teaching procedures? Are your interventions the cure or are they the trigger?
That is the question every behavior analyst should be asking themselves before they ever implement a behavior reduction plan.
If this helped you, follow behavioral intelligence, share this episode with another RBT or BCBA who's studying, and leave a comment or review. That's how we grow and how I keep creating high-level content for you.
At Amethyst Therapy Services, Inc., we build clinicians, not just test passers. Check us out at www.amethysttherapyservices.com or reach out at info@amethysttherapyservices.com.